Imagine billions of neural connections, governing movement and sensation, violently compressed into a space no thicker than your thumb. Because of this extreme density, even a microscopic interruption of blood flow, an ischemic event, produces devastating multi-system neurological fallout. Strokes higher up in the cerebral hemispheres typically cause uniform, dense motor deficits entirely on one side of the human body. But a brainstem lesion produces a unique clinical signature called alternating hemiplegia. Here, facial deficits occur on one side, while body deficits manifest on the exact opposite side. This split body pathology means the brainstem demands a totally different logical framework for diagnosis than the rest of the brain. Clinical localization in the brainstem is not an exercise in rote memorization. It requires mapping coordinates on a geometric grid. This diagram shows how we construct that grid. The vertical axis represents the long crossing pathways descending for motor control and ascending for sensory feedback. Intersecting them is the horizontal axis, which represents the uncrossed segmental cranial nerve nuclei operating at specific anatomical levels. This chart summarizes the definitive rule. It is the intersection of these axes that dictates the alternating hemiplegious presentation, pairing an ipsilateral facial deficit with a contralateral body deficit. To pinpoint a lesion's exact coordinates, we must superimpose the brainstem's precise vascular topography directly over this strict neurological grid. Blood surges upward through twin vertebral vessels, converging dramatically into the basilar trunk against the anterior surface of the brainstem. This arterial tree divides the brainstem tissue into strict, non-overlapping ischemic footprints. The architecture follows a strict general rule. Paramedian branches plunge directly into the midline core, while circumferential branches sweep around to supply the lateral edges. Looking at this cross-section of the medulla at the level of the olives, you can clearly see the stark divide between the blue anterior spinal territory in the middle and the pink and yellow lateral territories. Simply knowing whether an occlusion is medial or lateral gives us the exact formula to deduce a patient's symptoms. This illustration lets us zoom exclusively into the midline territory of the medulla, the paramedian region shaded in orange. The anterior spinal artery, or ASA, is the sole vascular supplier for this specific central column. This infographic shows ASA ischemia destroys the pyramids, yielding contralateral body paralysis. Simultaneously, damage to the adjacent medial lemniscus causes a contralateral loss of proprioception and fine touch. Finally, damage to the hypoglossal nucleus paralyzes the tongue on the exact side of the lesion. The interception of these ipsilateral and contralateral deficits maps directly onto the coordinates of the alternating hemiplegia grid. Now we shift our analytical focus to the dorsolateral wedge of the medulla, marked in red. The posterior inferior cerebellar artery, known as PICA, acts as the vascular supplier for this specific region. Notice a critical negative finding here. Because the medial paramedian zone containing the pyramids is completely spared, the patient will have zero motor paralysis in their limbs. This chart maps the lateral sensory fallout. Damage to the lateral spinal thalamic tract and spinal trigeminal nucleus creates a crossed sensory loss. Ischemia of the nucleus ambiguus prevents swallowing. Finally, severing the descending sympathetic tract induces an ipsilateral Horner syndrome. Wallenberg syndrome reflects the inescapable mechanical footprint of a PICA occlusion on the lateral axis. As we travel upward into the pons and midbrain, the identical vascular logic applies. It is simply mapped onto different local cranial nerves. This illustration shows the massive basilar artery resting directly atop the pons, where it sends short paramedian perforating branches straight into the midline. This graphic breaks down the catastrophic clinical outcome when a massive pontine hemorrhage destroys those midline structures: pinpoint pupils, extreme hyperpyrexia, and total quadriplegia. Moving higher still, the midbrain relies on the posterior cerebral artery and the superior cerebellar artery to complete the vascular map. Ascending the brainstem changes the segmental horizontal coordinates, but the fundamental rules of this vascular geometry never break. Brainstem syndromes emerge from the sharp division of the tissue's vascular supply. The anatomy splits into medial cores and lateral wedges, creating a predictable map of potential ischemia. a neurologist uses the physical exam, finding crossed sensory loss or alternating hemiplegia, to reverse engineer the exact coordinate of the stroke. Those coordinates map directly back to their strict vascular boundaries, the paramedian flow of the ASA, the lateral supply of the pica, and the deep perforators of the basilar artery. True clinical mastery of neuroanatomy requires visualizing this exact intersection of rigid vascular geometry and dense functional neurology. Applying the rules of a Cartesian plane to the brainstem grounds clinical neurology in the logic of spatial deduction.